The key word in all of this is may. Clinical research on hyaluronic acid injections is mixed. Some studies demonstrate modest improvements in pain and function compared to placebo. Are you ready to get back to what you love after knee replacement? The Total Knee Success Podcast is your trusted guide with practical tips, evidence-based strategies, and no fluff. It's not personal medical advice, just solid education to help you manage pain, regain mobility, and get back to living the life you love. Let's dive in. Welcome back to the Total Knee Success Podcast. I'm Michelle. This is part 2 of a 4-part series before total knee replacement. What injections really do. In the last episode, we talked about cortisone. Today, we're turning to gel injections, also known as hyaluronic acid injections. By the end of this episode, you'll understand what hyaluronic acid injections are designed to do inside the knee, what the research actually shows about their effectiveness, and how you might decide whether they fit into your overall knee health or surgical timeline. This discussion is educational in nature, and it's not a substitute for individualized medical advice. Your medical history, imaging, and surgical plan should always guide decisions in consultation with your orthopedic surgeon or healthcare provider. Gel injections are often described in very simple language. You may hear that they lubricate the joint or add cushioning to the knee. That description is not entirely wrong, but it's incomplete. Hyaluronic acid is a naturally occurring substance found in synovial fluid, the fluid inside your joints. Synovial fluid is mostly water, but it also contains molecules like hyaluronic acid, lubricin, proteins, and nutrients that help lubricate the joint, reduce friction, and nourish the cartilage. In a healthy knee, this fluid helps reduce friction and allows smooth motion. It also plays a role in shock absorption and joint nutrition. In osteoarthritis, both the amount and the quality of hyaluronic acid in the joint fluid change. The fluid becomes less viscous, meaning it loses some of its thick, slippery quality that helps the joint surfaces glide smoothly. The theory behind gel injections is that by injecting hyaluronic acid into the joint, they may temporarily improve the quality of that fluid. But this is not the same as rebuilding cartilage. It does not regrow joint surfaces. It does not reverse advanced osteoarthritis. What it may do is alter the joint environment in a way that reduces irritation and improves comfort for a period of time. Unlike cortisone, which works primarily by reducing inflammation, hyaluronic acid is thought to work through a combination of mechanical and biochemical effects. It may improve lubrication. It may influence inflammatory mediators, meaning it may interact with the chemical signals inside the joint that contribute to swelling, irritation, and pain sensitivity. It may stimulate the body's own hyaluronic acid production to some degree. The key word in all of this is may. Clinical research on hyaluronic acid injections is mixed. Some studies demonstrate modest improvements in pain and function compared to placebo. Others show minimal or no meaningful difference. And because of this variability, clinical guidelines differ on how they recommend using these injections. The American Academy of Orthopedic Surgeons, in its 2021 clinical practice guideline for non-arthroplasty management of knee osteoarthritis, does not recommend routine use of hyaluronic acid injections for symptomatic knee osteoarthritis due to inconsistent evidence of benefit. And that does not mean that hyaluronic acid never helps anyone. It means the average effect across large populations has not consistently demonstrated strong benefit. Because responses vary from person to person, some clinicians still offer hyaluronic acid injections selectively, especially when a patient prefers to explore conservative options and understands that the expected benefit may be modest. In parts of Europe, some treatment guidelines allow hyaluronic acid injections as a later step in non-surgical management when other conservative treatments have not provided enough relief. In Australia, clinical guidance similarly notes that evidence is mixed but recognizes that some clinicians may consider a trial of hyaluronic acid in selected patients. In some cases, clinicians also use hyaluronic acid injections as a temporary bridge when symptoms are bothersome, but surgery is not yet planned or the timing is not ideal. When benefit occurs, it's often gradual. Unlike cortisone, which may provide relief within days, hyaluronic acid injections typically take several weeks to show potential effect. Some formulations involve a single injection, while others are delivered as a series of injections over several weeks. For individuals who do experience improvement, relief may last a few months. For others, there may be little to no noticeable change. I've seen several patients who have had significant relief, and I've seen several patients in the physical therapy clinic who've had no relief at all. This variability can be frustrating, and it can influence expectations. One important distinction between cortisone and hyaluronic acid is perceived structural impact. While some studies have raised questions about cartilage volume loss with repeated corticosteroid injections, hyaluronic acid has not demonstrated the same signal of accelerated structural progression in current research. However, the fact that hyaluronic acid has not shown the same signal of cartilage loss does not necessarily mean it produces meaningful symptom improvement. So, how should you think about gel injections before total knee replacement? First, consider severity. In mild to moderate osteoarthritis, some individuals report more meaningful benefit from these injections than those with advanced bone-on-bone arthritis. In advanced cases with significant deformity and joint space collapse, the magnitude of relief is often limited. Second, consider your timeline. If surgery is being considered within the next few months, initiating a multi-week injection series might not be practical. If relief occurs, it may overlap with conversations about surgical timing. And third, consider your primary goal. Are you hoping to delay surgery for a specific reason? Are you attempting to maximize comfort during a period of life transition? Are you exploring every non-surgical option before making a decision? Clarity around your goal shapes whether this intervention fits. It's also important to understand that hyaluronic acid injections are not universally covered by insurance plans. So cost considerations sometimes influence decision-making, and those conversations are reasonable to have with your provider. From a functional standpoint, the same principle applies here as it did with cortisone. If you haven't listened to the cortisone episode, go back to episode 51 and take a listen. Back to gel injections. Pain reduction does not automatically equal improved capacity. If a gel injection decreases discomfort, that period becomes an opportunity to strengthen your quadriceps. You've heard that from me before. An opportunity to improve walking symmetry, an opportunity to restore knee extension or improve stair control. These are all great opportunities. And you're hearing this from a physical therapist. If relief occurs, but strength and mechanics are not addressed, symptoms may gradually return without meaningful change in overall trajectory. There's another psychological layer also to discuss. Because hyaluronic acid injections often take longer to show effect, the waiting period can really create some uncertainty. You might wonder whether it's working. You may analyze every step for signs of improvement, and that mental load can influence how you perceive your symptoms. Understanding that potential improvement is gradual can reduce a lot of frustration. So let's address a common belief. Some people assume that because these gel injections are a naturally occurring substance, it must be safer or more restorative than corticosteroids. Natural doesn't automatically mean restorative. Hyaluronic acid injections are generally considered low risk, with potential side effects including temporary swelling, soreness, or inflammatory reaction at the injection site. Serious complications are uncommon, but no procedure is entirely risk-free. And another important point, hyaluronic acid does not prevent the need for surgery if structural degeneration progresses to a level that significantly limits function and quality of life. It may delay surgery for some individuals. It may not change the ultimate decision for others. A thoughtful way to frame gel injections is this. They are a potential comfort-modifying tool, but they're not a structural solution. If you and your surgeon determine that your knee arthritis is advanced and your symptoms are significantly limiting, it's reasonable to ask whether a temporary intervention meaningfully alters the overall plan. If your symptoms are moderate, fluctuating, or activity-specific, and you're working on strength and conditioning, a trial of hyaluronic acid may align with your broader strategy. There's no universal right answer. The answer is for you to choose. The real question is whether the option in front of you fits your knee, your goals, and your timeline. From a rehabilitation perspective, if you choose to proceed with gel injections, monitor not just pain levels, but functional markers. Are you walking farther with better control? Is stair descent more stable? Does swelling remain reduced after activity? Are you able to tolerate progressive strengthening without flare-ups? These indicators provide more meaningful information than a single pain rating. If improvement is minimal after an appropriate waiting period, that information is useful too. It suggests that improving joint lubrication alone might not be the main factor impacting your symptoms, and that clarity can support confident decision-making. Before we close, I want to emphasize something worth remembering. Choosing to try a gel injection does not mean you're avoiding surgery out of fear, and choosing not to try one does not mean you're rushing into surgery. These are tools within a spectrum of options. The goal is not to exhaust every possible injection. The goal is to make deliberate, informed decisions that support your long-term function. If surgery is part of your future plan, preparation becomes the next important step. Many of my patients tell me that preparing their home was the single best thing they did before knee replacement surgery. And when I shared my 2-week knee replacement launch plan with a close physical therapist friend who recently had a knee replacement herself, she immediately said that setting up her living room chair, her resting station, before leaving for the hospital was one of the best things she did. This launch plan is yours free. Just click on the link in the show notes or go to totalkneesuccess.com to download and print it absolutely free. In the next episode, we will examine platelet-rich plasma, commonly referred to as PRP. This is another injection type that's frequently discussed in the context of knee osteoarthritis. We will explore what PRP is biologically, what current evidence shows, and how to evaluate claims surrounding regenerative medicine. As we continue this series, remember, the more clearly you understand your options, the easier it becomes to make decisions that support your long-term knee health. I'm Michelle. Thanks for joining me. This has been the Total Knee Success Podcast. This podcast is for educational purposes only. Discover more at totalkneesuccess.com and be sure to subscribe and share because every step forward takes you closer to living the life you love.